So maybe we could turn then a little early to Dr. Tommy Brothers, who's going to be speaking about can we make hospitals safe for people who use drugs? Dr. Brothers helped organize Halifax's first safe injection site. His clinical and research work focuses on improving healthcare for people who use drugs. Good morning, welcome, and thank you for being here, Dr. Brothers.
Thanks very much, Randy, and all the organizers for having me. It's wonderful to see such a turnout. Can everyone hear me okay and see the slides? Great. So as Randy mentioned, I'm a medical doctor. Most of my clinical work is based in the hospital, and my focus in education and research initiatives has been trying to figure out how to improve hospital care for people who use drugs. Debbie shared a really powerful story earlier about the potential for improvement. And my title about can we make hospitals safe for people who use drugs is meant to be a bit of a provocative challenge, implying that right now most hospitals are not safe. But of course, we want to aspire to something greater and make hospitals a place of healing and caring for people who use drugs. Just to start with some acknowledgements, I live and work in Mi'kmaq, which is the ancestral and unceded territory of the Mi'kmaq, and we are all treaty people. I don't identify as a person who uses drugs and won't claim to speak from that perspective today, but the information I share is made possible by the generosity of people with lived and living experience of criminalized drug use who have shared their knowledge and experience with me. And that includes colleagues and friends, as well as my patients. And I have no relationships with the pharmaceutical industry. There are 4 key messages that I'm hoping you'll take away from this session today. The first is that people do not give up their right to healthcare just because they use drugs, even though some of the policies and practices in hospitals might imply that they do. Second is that patients come to the hospital for necessary and needed medical care, often as a last resort because they've had such negative experiences there, and not necessarily because they want to stop using drugs. So it's not fair for us as hospital-based health professionals to assume that people are able or interested in stopping right now just because they need antibiotics or surgery. Number 3 is that hospital policies that require abstinence, and these can be written or unwritten, but that require abstinence in order to receive medical care create harms for people who use drugs. They're not neutral, they're actively creating harms, and I'll walk you through some examples for those that may not be as familiar with the hospital setting. And finally, the hospital should strive to at least offer the standard of care provided by community-based harm reduction programs, including the ones that we've heard from so far. But of course, recognizing the amount of resources that hospitals have that community-based organizations don't, of course, we should aspire to offer even more. So we've already heard today about a lot of the threats and risks facing people who use drugs, the toxic and poisonous criminalized drug supply, discrimination and stigma, pushing people away from healthcare, lack of housing, of affordable housing, creating the harms associated with homelessness. And in order to navigate these social harms and get through the day, people who use drugs rely on a wonderful network of harm reduction programs and organizations that we have in the Maritimes with a rich history, as we already heard about this morning, for things from social connection and support and navigation, practical supports with sterile injecting equipment and naloxone, opiate agonist treatment, methadone, Suboxone when they need it, if people need a break, support with housing, all these kinds of things. But when it comes to hospital settings, places that are supposed to be healing and caring, not only have we traditionally not offered those services, we haven't taken that philosophy of care, and we've often barred these kinds of supports at the door. They're not invited into the hospital. People are not on the care team. There's no communication and coordination. And as I mentioned at the beginning, often abstinence is enforced or expected in order to follow the hospital rules. So hospitals have been conceptualized as high-risk environments for people who use drugs. The abstinence-only policies, the lack of harm reduction support, and stigma keep people away from hospitals because of these negative experiences until, for example, a skin infection might worsen and become more severe and enter the bloodstream and spread to the heart. They lead to inadequate pain and withdrawal management, people having terrible experiences in hospital, and they lead to people leaving hospital before their needed medication and other treatments are done because of the hostile environment that we've created. So the end result is increased morbidity and mortality, increased suffering and death, horrifically and terribly for people who use drugs when hospitals are supposed to be places of caring. I'm going to just show you briefly some of the research evidence around this. This is a bit of an older paper now, based in Vancouver, but it shares the stories of people who use drugs who have been in hospital. And this is based at St. Paul's Hospital in Vancouver, which is really a leader in terms of integrating harm reduction into hospitals. So some of the policies they have now weren't in place at the time, but at that time they were still thought to be a leader back in 2014. So I have 4 quotations that I'm going to share with you. And I apologize for those with lived experience in the crowd that these may provoke some strong feelings, because the stories of how people are treated are quite awful. I had to get out of there while I could move because I was losing so much weight. I begged and begged to get some help, i.e. prescription opioids for treatment and relief of withdrawal. They couldn't, they weren't going to do anything. So I just said, fine, I'm leaving. I was concerned about the health consequences of leaving hospital, but I've got this other thing, opiate dependency. And it's like you're stuck between a rock and a hard spot. I mean, how can I fight off infection if I can't stop puking and shitting? Second, the security guards yell and scream at you. When there's nobody around, they say, "You effing junkie." A few times I've been shaken down or searched by security guards, even though I had nothing to get high, no drugs in their possession. They search you, destroy your property, cause a scene, and make sure everybody in there knows you're a drug addict. They use their authority to pull power trips, more or less. It's not right. So, here we have people seeking medical care, trying to engage in the treatment that they need, and being forced into withdrawal, being judged, being discriminated, and getting pushed out of hospital. And as we know, that loss of opioid tolerance that comes with forced withdrawal can be deadly as soon as people leave hospital after a period of enforced abstinence in the hospital, with higher risk of overdose. 2 more to share with you. The nurses don't give you rigs or syringes. I think they should. If not, we're reusing our rigs. We're having a risk getting kicked out for stealing them, or people will be sharing them. I know one girl was using her same rig for days to the point it was tearing. She was suffering every time she'd do her fix. She just didn't have it in her to go and try and steal clean rigs. Whereas for me, my friend I was with had no problem. She would sneak in and grab some for the both of us. And the final one here, if you're sharing a room with somebody, there's always that threat that someone's going to come in and not realize you're in there in the bathroom and open the door. I think they pretty much have a zero tolerance in the hospital, a zero tolerance policy for substance use. I was worried about getting kicked out and not getting the proper healthcare I needed to get better. I'd turn on the tap. So if they came into my room to check to see if I was okay, they'd hear the water running. So they'd figure, oh, she's just in the bathroom. So here we have examples of the hospital policies and practices creating risks that wouldn't necessarily be there otherwise. So someone who relies on a needle exchange, a harm reduction program for their own safety to use clean and sterile equipment is denied access to it, even though they're stuck in the hospital because they're a patient. So they're having to reuse blunted, contaminated equipment, increasing the risks of infections. And somebody who uses substances, presumably every day, doesn't have a safe space to do so, doesn't have people to use with. And so they have to lock themselves into a bathroom because they fear getting kicked out of the hospital, even though they need treatment, so that nobody could respond with naloxone if they overdose. So this is kind of some examples of what I'm talking about with the policies and practices creating harm, creating a hostile environment. This is an example of the qualitative research. I just want to show you an example of the quantitative research of the consequences of some of this harm. So this is a study published this year I was involved in. We looked at all of the opioid overdose deaths in England in the past 10 years and looked at when they happened in relation to when people were in hospital. We found that the couple of days after hospital discharge, people are at a 4 times elevated risk of a fatal opioid overdose. And if they're discharged prematurely against medical advice for those reasons that we talked about, the risk is increased 8 times. So the harms conferred by hospitals are quantifiable. I would argue that they're preventable and reversible, and we'll get into some examples of how that might happen. But I think all of us who work in a hospital setting have there's many reasons, obviously, why we have a mandate to do better. So how are we doing locally? I want to show you some local data next. This is a project, the paper was published this year. The data, we looked back a bit older for the time when I started residency from 2015 to 2017. And that's because this was the practice environment, these kinds of issues of how things were in Halifax when I started my training in medical school and residency. And so we wanted to try to identify what happens to people when they come into hospital in Halifax. I had learned about some of the great work going on in St. John, some of the initiatives led by the Division of Infectious Diseases and Duncan Webster. And so those hadn't been evaluated. So we wanted to compare the experiences of people in hospital in St. John and in Halifax. And we wanted to identify the people who would be, we would argue, at highest need of all of these supports. So we found the hospital admissions and records of patients who are admitted with endocarditis from injection drug use. And for those who maybe aren't medical, endocarditis is a bacterial infection of the inside lining of the heart and the heart valves associated with injection drug use. And, it can be very dangerous. It can be deadly. People need to stay in hospital a long time. And so these are the folks we argue would be at most need for all of these supports that we're talking about. So the hospitals in Halifax and St. John are a bit different. The situation that existed in 2017 is still largely the same today. So as I mentioned before, both hospitals have harm reduction programs and organizations in the community that offer all of these sorts of things we've been talking about. Both hospitals are also highly specialized. With lots of resources. They're the main teaching hospitals for the Dalhousie Medical School. They have cardiac surgery programs if patients need operations on their heart valves. They have infectious diseases specialists, cardiologists. At the time, St. John had some institutional policies that acknowledged substance use and incorporated harm reduction, including an inpatient needle exchange and needle and syringe distribution program, which I believe was the first in Canada. At the QE2 in Halifax, we don't have that. We still have no policies, and we've had to really do things on a case-by-case individual basis while we're going through that slow process. And as I mentioned, St. John has the inpatient needle exchange. In St. John, the infectious diseases physicians and some of the other hospital-based physicians got extra training in prescribing methadone and buprenorphine or Suboxone so they can offer it to people who are in withdrawal or interested in starting treatment. In Halifax, back in 2017 and still today, there's nobody on staff that has this training or is able to start people on medications, which is kind of amazing if you think about it. So again, we've had to go outside the normal rules of the institution, and I'll show you that after this. Neither hospital, as far as I know, folks in St. John, please correct me if I'm wrong, have a role for someone with lived or living experience of substance use on the hospital care team. So that's also something we can aspire to. This is just some brief examples of the policies in St. John. The original needle exchange policy. There's process maps for identifying and urgently treating opioid withdrawal with methadone doses, and protocols, checklists to facilitate that care with as few barriers as possible, which we also haven't had in Halifax. So the first thing that we looked at was access to opioid agonist treatment. So as I mentioned, patients who use opioids who are in withdrawal, and these were folks who were not already on methadone or Suboxone or KDM when they came into the hospital. So these vertical bars here, the black is Halifax, the white is St. John. 100% includes all of those patients with endocarditis from injecting drugs who used opioids. The next pair here is who was offered opioid agonist treatment in hospital. So because the infectious diseases specialists in St. John prescribe these medications and can initiate them in hospital, 100% of these patients were offered it, whereas less than half in Halifax were. Obviously a huge gap of unmet need and a huge difference between the two hospitals. But if you look at these next two pairs of columns, the third one is how many patients actually started it when it was offered. And the final one is how many continued on with a prescription after hospital discharge. So most patients, once it was offered in hospital, were interested in trying treatment or starting it with OAT, and were interested in continuing on after hospital. So lots of unmet need, but lots of opportunity for people who are, unfortunately very sick from serious bacterial infections related to injection drug use and homelessness and all of the criminalization and all the harms we've been talking about, but are interested and open to starting on opioid agonist treatment. In terms of who was provided sterile injecting equipment in the hospital, as I mentioned, St. John, I think was the first program in Canada. That policy was developed on their internal medicine unit where some of these patients, many of them were admitted. If you look at the left column here, this was 21 hospitalizations to people in hospital with injection drug use associated endocarditis in Halifax. None of them were offered sterile injecting equipment in hospital, perhaps not surprising because there was no policy in place. There still is no policy in place. And unfortunately, 5 patients or almost a quarter had their own equipment identified by hospital staff and confiscated. So these are people who are trying to be safe, who are trying to use sterile equipment, and the hospital is actively making it worse and actively creating harm, as we talked about before. Compare that to St. John. On the right, 4 patients, or just under a quarter, were offered sterile injecting equipment in hospital. That's wonderful. It's obviously not everyone, but it's great that some people have access to this and did at the time. And yet 2 patients also had their own equipment confiscated. These were different patients at different hospital times, but one of the same units actually had was offering patients equipment at one point and confiscating it at another. So, policy can be more consistent. Obviously, it takes a lot more to implement a policy in terms of education and practice norms than just having it on paper. So perhaps a lot more room there in terms of the inconsistency, but better than nothing, we would argue. And then the final thing we looked at was patients' experiences in the hospital and indicators of unmet care needs related to substance use. The information source where we got this was the medical records. So this relied on charting from nurses and physicians and pharmacists and social workers. So I'm imagining that this is an undercount in terms of what happened to people. But remember that these are folks with life-threatening bacterial infections. And so my argument is that we should be doing everything we can to support people to stay in hospital, to be free from pain, to get their antibiotics, to get their surgery if they need it. In this first row here, you can see most people at both hospital sites, there was documentation in their medical record about providers' concerns that the patient was experiencing uncontrolled pain or undertreated opioid withdrawal. Around a third in both hospitals, there was documented concerns about ongoing substance use in hospital. Of course it happens, right? Patients were injecting drugs yesterday, injecting drugs this morning, got a fever and a bad infection, came into hospital. Of course, they're still going to need to inject, or many of them will. And so hospital policies need to acknowledge that this happens and need to support people to do it safely. And finally, around 10% or 1 in 10 of patients at both hospitals left their hospitalization prematurely before their treatment was completed. So what more can we do? How can we make things better? I'm going to show you one version of my menu of things that I think are easy for hospitals to achieve, things we've been working on in Halifax, and I know folks have been working on, including some who are here today, have been working on in St. John. I'm going to read you my menu and then give you some examples of each. So in hospitals, we need to provide compassionate care, culturally safe care for people who use drugs. I think Debbie gave a great, powerful example of what that might look like this morning. I'll give you a couple more. We need better staff education, training, and culture change around substance use in hospital. We need people who use drugs involved in leading service planning and delivery. We need opiate agonist treatment on demand. You saw there that most folks who are quite sick would like a break, would like to try opiate agonist treatment, and we need to be able to offer it to them and continue it if they're already on it. Of course, people can't go without and be experiencing withdrawal unnecessarily in hospital when they're trying to be well. We need to offer short-acting opioids like hydromorphone, morphine, Dilaudid for pain and withdrawal, whether or not people are starting on opiate agonist treatment. We need to distribute safe injecting equipment in the hospital, including needle disposal kits, but people should have unlimited access so that they can stay safe. We need to incorporate safe consumption sites and overdose prevention sites into hospital. As I mentioned, of course, people are going to be using in hospital. We want them to stay. We want them to access their treatment, their medical treatment, antibiotics, surgery, that kind of thing. So we can't be creating environments where people need to lock themselves in the bathroom or leaving the hospital grounds. And I argue we need specialized addiction consult services or perhaps just medical substance use services to be able to take on these higher prescribing doses to be champions of culture change. That could be addiction trained physicians and nurse practitioners and nurses, or it could be the infectious diseases specialists taking this on for these patients with endocarditis, like the folks in St. John have done and been leaders in. So I'll show you some examples of each. So what would culturally safe care look like for people who use drugs? This was a research project done in Victoria, BC, a collaboration between the drug user group there, Solid, and researchers at UVic. And they got together and asked their membership, how would you like to be treated in hospital? How should care providers treat you, and what would help you feel safe? So there's a few recommendations they came up with. The first was to foster engagement and participation of people who have experience with substance use and marginalization and shaping the care they and their peers receive. Number two, recognize people's healthcare and priorities and experiences are influenced by history and policies that criminalize drug use. Number three, consider how past histories of trauma and violence, layers of disadvantage and stigma may affect patients' ability to engage with providers and care plans. Number four, emphasize relationships and trust as priority outcomes. I do really appreciate this one. Sometimes as medical people and clinicians, there's a lot going on in people's lives that's outside our control. And for example, people will need to leave hospital kind of no matter what we do because they have other priorities. But I appreciate that people who use drugs are asking us to treat those relationships and trust as an ends in their own right, as an outcome in their own right. And finally, promote a culture of respect and safety within the unit or workplace where all patients are valued and seen as deserving of care. So these are teachings and lessons that we're incorporating into our educational sessions with physicians and nurses and pharmacists and social workers and trying to, and medical students, I should say, and trying to change some of those attitudes. I don't think that this would necessarily be a controversial way to treat any patient. You know, as health professionals, we talk about patient-centered care. I think these are great examples of that. It just sometimes takes a special invitation when we're having to unlearn a lot of things about how drug use has been criminalized and how people who use drugs are. And one story I appreciate about this project, Bernie Polly shared, who's one of the lead researchers, was the drug user group developed it in order to, you know, post these handouts on the wall and share them with providers and say, you know, you should think about providing care this way. And then the drug user group started printing it out and handing it out to their members. And so when they went to access care or they went to the emergency department or hospital, they bring a handout with them and say, this is how I want to be treated. And this can be incorporated in a hospital policy. So this is an example from Alberta Health Services. It's an overarching province-wide health policy guidance document for all of Alberta Health Services. Some of the language has been changed since the new Conservative government came into power, interestingly, but it's a model for us that we've been borrowing from in Halifax as we're developing some draft policy changes. So this is in the written, province government policy. Patients who use psychoactive substances have the right to receive equitable, non-judgmental, and evidence-based healthcare services, regardless of whether the substances they use are legal or illegal. Individuals with lived experience have expertise to contribute as partners in the creation of programs, policies, and harm reduction strategies designed to serve them, and their input is valued and respected. Obviously, that has to be met with funding and logistical and institutional support for that expertise to be incorporated on the leadership team. And finally, program services and healthcare providers across the care continuum shall provide low threshold access to harm reduction services, treatment, and or referral for patients. So every setting on demand, all of these services should be available. In Halifax, as I mentioned, we haven't had anyone on hospital staff, physicians, or nurse practitioners that has the skills or takes it within their scope to offer opioid agonist treatment initiation in hospital. So we organized a team of residents that are working at the hospital, supervised by and led by addiction physicians in the community. Some of you may recognize these names. John Fraser, who's been in practicing and leading this work in Halifax a long time, has been our primary supervisor and mentor. We would be able to do that with this without him. So this team operates outside of working hours, evenings and weekends, and gets referrals by word of mouth, text message from our peers in the hospital. We offer all patients who use opioids, short-acting opioids for pain and withdrawal to help them stay in hospital. And we offer everyone opioid agonist treatment. And in our evaluation here, we found almost all patients with untreated opioid use disorder who were in hospital with serious complications from injection drug use started treatment in hospital, and almost all of those who started continued it at discharge. So we argue this is a huge unmet need, a huge gap in care. If there's anyone here from Nova Scotia Health, please connect with me afterwards. We've been trying to get funding to make this service real and resourced and available during business hours since 2018, but we still haven't gotten anywhere. An example of how a needle exchange can be incorporated into hospital. I showed you briefly the original one from St. John. This is from Providence Healthcare in Vancouver. They call it, this is a nursing care guideline. They call it the Unsafe Sharps Risk Support Plan. The argument is that if we do not offer patients sterile injecting equipment in hospital, that leads them to have to hold on to their used equipment and hide it under their mattress or hide it in the peanut butter drawer and reuse it. And not only does that create harms for the patient in terms of risks of infection, as I mentioned before, but that's where the risk of needle stick injuries from hidden needles might come to hospital staff, including nurses and housekeeping and that kind of thing. So by offering patients an unlimited supply of sterile injecting equipment and a disposal kit, we're not only helping people stay in hospital and stay safer, but we are helping reduce the risks to staff as well. So like lots of harm reduction. This is win-win for everyone. But of course, people use drugs in hospital. This is the reason that we have to give them sterile injecting equipment and disposal kits. So we need safe consumption sites and overdose prevention sites in hospital as well. This is one where we're a bit further away from achieving in Halifax. So this is an example of the supervised consumption site at the Royal Alex in Edmonton. It's a room inside the hospital. They have 2 different injection rooms and a chill out room. It's available to hospital inpatients or patients registered in the emergency department. It's staffed by nurses, and they've used this infrastructure to build in an injectable OAT program, so liquid hydromorphone, liquid high-dose hydromorphone in the same infrastructure. So patients who are admitted in the hospital can come here and use and not miss antibiotic doses and not have to leave the hospital grounds and be able to stay safe and stay inside. a different model of an overdose prevention site at St. Paul's Hospital in Vancouver. It's been in their courtyard behind the hospital. It's been in a trailer in that courtyard. It's been in the ground floor basement of the hospital. But it's staffed by peer workers with lived experience of substance use from a community organization. It's accessible by patients who are in the hospital, but also just by community members in the surrounding area. And it's really minimal. Like I mentioned, it was a tent, it was a trailer. You don't necessarily need, as we know from overdose prevention sites, you don't necessarily need all of the expensive infrastructure, the medical professionals or healthcare professionals. These services can be much more effective if they're staffed by people with lived and living experience of substance use. So these are just a couple of examples of what it could look like in the Maritimes. We can incorporate the supervised consumption site model, the medical model, or simply put an overdose prevention site on the hospital grounds for anyone to access. I want to share, to wrap up, a couple of key resources here. If you hold your cell phone camera up to the QR code there, it should take you to a Google Drive folder that has the paper that I shared with the data from Halifax and St John, and also these resources. So one is an overview that Duncan and John and I wrote in CMAJ on some key principles in caring for people who inject drugs in hospital. And the second one there is from a group at McMaster in Hamilton about many different aspects of how hospital policy can be transformed, or as Julie challenged us to think of things upside down, to support people to stay in hospital and make hospitals a caring and safe space for people who use drugs. And I've learned a lot from that group and incorporated some of those ideas into this talk today. And I'm happy to share these slides as well, of course. So to wrap up, I just want to repeat the key messages that I was trying to communicate with this session. The first is people do not give up their right to healthcare just because they use drugs. Second, patients come to hospital for necessary medical care, not necessarily because they want to stop using drugs. And so we need to help people stay alive, as Julie mentioned, and treat the needed medical problems while supporting them to stay safe. Number three, hospital policies requiring abstinence create harms for people who use drugs. They're not neutral and they need to be changed. They're causing people to die, as I shared with that quantitative study. And number four, hospitals should strive to at least offer the standard of care provided by community-based harm reduction programs. But of course, I argue with all of the resources and specialized everybody available at the hospital, we should aspire to have even more. And finally, this is my contact info if people want to reach out, but I hope we have time for questions and discussion now as well. And thanks again for inviting me to speak on this topic. It's something I care deeply about, but it's obviously a work in progress for us in Halifax.
Hey, Tommy, it's Sarah Gander. I'm your chat question person. So I've just been watching a really dynamic conversation in the chat throughout your presentation. And thanks as always for being awesome. So lots of support and lots of kudos to you for all of your hard work. One question that came out in the chat was just sort of what your wish list would be in the Atlantic provinces for what research and scholarship we could be doing that in particular might meet our specific needs. So whether that be our specific needs like related to the drugs that we do see in the Atlantic provinces, or if there's a specific issue with our law enforcement in this region or what have you. Do you have any thoughts on what research could kind of be the next thing that might, keep the momentum going?
Yeah, do you mean specifically related to hospital care or kind of more broadly, more generally related to?
The question was asked overall, but I think because they spoke about sort of police and things like that, but I just think like what would be next in sort of better understanding the path that we should take moving forward?
Yeah, I have a couple thoughts of that. It's a really important question. I think the fundamental way to get at what's most important would be if people who use drugs and the drug user groups we have in Atlantic Canada can be supported to participate in setting that agenda and asking those questions. And I know Sunar has been doing really great work doing that. I know Kapud, which is now based in Dartmouth, Nova Scotia, has been doing that at a national level. Debbie mentioned the national networks, the ongoing study in the Atlantic looking at access to treatment. Most of the answers I could give you are really ideas that have been shared with me from people who use drugs, about our changing and unstable drug supply in the Maritimes, where previously pills have been widely available, and now there's more and more pressed pills that are actually fentanyl and all the different contaminants and are no longer safe for people. So there's more and more of a role of safe supply. The way that medications like safe supply can try to counteract some of the social harms like homelessness and poverty and violence that are facing people's lives. But my real answer to your question would be, I'm probably not the best person to answer that. But our emerging and established drug user groups in Atlantic should be at those tables, supported to be at those tables, paid for their expertise, and invited to set that agenda for us to follow.
Yeah, for sure. And I wanted to, there's a couple of questions. Well, one is that if you mind sharing your slides, which knowing you, oh, there you go. Maybe you're already sharing them. Is that what that Google Drive link is?
That's the link to the Google Drive with the papers in it. Oh, and I also
okay.
I didn't mention there is one best practice guidance document on caring for people who use drugs in hospital that's published out of that group in Alberta. And there's a PDF of that in that folder as well. And that's what we've been bringing to hospital leadership and saying, this is what's established as best practice, and this is what we have to aspire to meet. We're not kind of making this up as we go. And I'd be happy to, I'll pop my slides into that folder so that everybody can access them as well.
Awesome. So one of the questions was, where do you think from a hospital standpoint, some of these facilities or infrastructure opportunities for folks is best located, which is actually kind of what my question is too, but maybe I'll let you answer that and I'll dovetail onto that.
Like physically located, or
yeah, I think so.
Yeah.
So the question reads, I realize this program crosses over in all departments in the hospital at like QE2, but where in your opinion do you think it is best located? Oh, look it. And the person said yes, that I must have got it okay. So like physically located.
Yeah, I think that different components of it can be located in different areas. I think there's obviously some aspects of changing care and changing culture and changing practices that really do need to be distributed across the whole hospital. So for example, our team that's trying to take this on is comfortable prescribing higher doses of opioids than many other physicians would be. And so if they can reach out to us and we can go and participate in caring for that patient and guide medication dosing or take over medication dosing, whether that patient is admitted to a surgical floor or a medical floor or anything like that, like that's incredibly important. Can we distribute sterile injecting equipment throughout the hospital in many places so that people can access it? Maybe a vending machine would be really helpful so that people don't have to disclose and can get it anywhere. One of the restrictions on safe consumption sites and overdose prevention sites is that they're kind of geographically fixed. So having it in a location that may be a bit more private to access, but is still open to the community could be a win-win. There's a treatment unit at St. Paul's in Vancouver that was previously their inpatient AIDS unit that's been redesigned and reorganized to support people who use drugs who are admitted to hospital with complications of injection drug use. And by keeping all those folks in their hospital beds in the same area, they're able to offer a multidisciplinary team that involves people from the community that they know and representatives of all of the housing and harm reduction programs that can come and be part of the care team. So that kind of having a specialized area in the hospital that we could offer to people would be wonderful. So it's not really to answer your question, but I think some things need to be hospital-wide, some things can be concentrated, and then perhaps they should coordinate themselves together.
Yeah, well, I think some of the chat was, it's fine. It's all well and fine to have some of like the great initiatives that we have here in St. John, say on like one nursing unit, but then if you can't extend that to other nursing units, like you kind of never know when somebody might be somebody who would benefit from those services. And so how does it kind of cross the hall to the other nursing unit? And I think someone mentioned that then even if the nurse or one of the healthcare providers has that experience, it's almost not an accepted practice in a different place. So how can we kind of make it more ubiquitous and available out in the community and in the different hospital areas? So
yeah,
that's
I
more
think
just
that's
a comment
where
than a question.
No, yeah, and I that's great, and something I've been thinking about a lot as we've been trying to kind of change culture and attitudes. I And I think it's a good example of where education and stigma reduction are necessary, but not sufficient. Like they can do so much, but if you don't have policies in place or college regulations in place or things written down on paper that say, this is how we should be thinking about these issues, this is the type of care we want to offer, this is how we want to embrace people and keep them safe. Attitudes can be positive, but people's practices are quite limited. So I've learned a lot from nursing colleagues about what they feel they can or can't do because of real or unclear restrictions on their practice from the nursing college. And we've seen similar things happening with the medical community and safe supply prescribing, where people feel like they can't embrace a harm reduction practice because they would fear their license from their regulator. So, education and stigma reduction is important. Explicit hospital policies are necessary. College standards are necessary. And so there's a lot that has to happen at lots of different levels for this to be successful. But I have some really funny conversations with people when I talk about this stuff. And they say, hey, why haven't we been doing this the whole time? Like, why are hospitals so hostile and why haven't we been doing? I'm like, I don't know. I'm sure there's
except for we kind of do know.
Yeah. all the discrimination and the stigma and the criminalization and things we've been talking about, for sure.
But they're very difficult.
There's really no reasons we can't, basically.
Yeah. There's so many questions, Tommy. So I hope just settle in. So, because we've got lots of time. And to continue on to that vein of thinking, we have a anonymous attendee who sort of said, from an educational side, how are we working then to integrate this mindset and approach in educational institutions in making changes before folks enter the healthcare working environment? So do we have an opportunity to work with educators too?
Yeah. We've had a really positive response from nursing educators at the QE2. We've had a really positive response from the medical school and the people that make the curriculum. But honestly, the most encouraging response has been from the new generation of students, of nursing students and medical students and pharmacy students. I think in so many ways, the young folks, the Generation Z, are going to save us. It's people are looking for educational opportunities when they're entering the health professions. People want to learn how to do this. It felt horrible being a medical student and participating in care that was creating harm for people who use drugs. I could tell what we were doing was wrong, but I just didn't know what we could do differently. And it was clear on our team, we operate in big teams in the hospital, being supervised, different levels of seniority. Nobody felt good about it. There was a lot of moral distress. There was a lot of people asking questions, but really not connecting the dots. And so where I've learned so much has been from the community harm reduction organizations, from people who use drugs, and just trying to bring these established ideas, these evidence-based ideas and practices into the hospital and say, hey, there's people outside these walls that have been doing this for decades. We should think about doing it here. So there are lots of opportunities, I think, to improve medical school curricula, nursing school curricula, educational in-services. We've had a bit of a struggle connecting with bedside nurses because of the way that their shifts work and people not being able to all take breaks at the same time. But that's one thing where these specialized consult services can make a huge impact, because every patient that we care for together with a nurse at the bedside can be opportunity for dialogue and two-way education and learning about best practices and evidence and learning about the realities of providing care in the hospital and all those kinds of things. So I think there's lots of opportunities. I don't have a single best answer, but leveraging the expertise of community-based organizations and inviting them into the schools and the hospitals, I think is key.
Mm. I wonder too about my own personal experience working in the hospital, and particularly with COVID and the pandemic. And so this has sort of triggered me to ask this, when we were working with COVID and some of the regulations, albeit early, particularly during the early days when there was really little to no flexibility with how we let people move around in the hospital, or, and it wasn't just injection drug use. It was going out for a smoke. It was going out to grab, Wendy's so you didn't have to eat the hospital food, sort of thing. How can we learn from the pandemic in terms of meeting people where sometimes you do have to come and go and have some privacy and move amongst places to meet people's needs? Because I think we are still seeing in the hospital that you're kind of, when you come in, you're especially if you have COVID, you're in your room, you're not going anywhere, you're staying in that room, nobody can come see you, you can't leave. And there's some good reasons for those decisions, but then and really no flexibility about how to meet people's needs. And then what would happen? People would get upset. There'd be a code white. They'd get, the police would come and then here we are in the same re-traumatizing situation we're trying to avoid.
Yeah, COVID and the visiting restrictions and the mobility restrictions in the hospital have been really horrible. And, even more so, like most things, people who use drugs have taken the brunt of those harms. I think it's a good example of there's some things that are bigger picture, like infrastructure changes are needed, private rooms are needed, better ventilation and infection control. These are more expensive, longer term projects. I think later this afternoon, one of the discussion topics is on COVID and harm reduction, but with every crisis comes opportunity. So as people have had to isolate, it started in Halifax with the hotel shelters. I was on a team with MOSH, able to provide people emergency managed alcohol and safe supply medication, so they had to isolate. And we have taken that approach to some folks in the hospital on the COVID units, who we're basically asking them to do the impossible and stay in hospital when they're sick. And be able to provide safe supply in the hospital on a individualized case-by-case way. So some of the problems are massive and are going to require big, expensive structural solutions. Some of them, I think, require looking for those opportunities to continue to try to stay dynamic and creative, and provide the best care we can to help people do things that we're asking them to do that are impossible, to help people stay safe. So always that mindset about, what more can we offer when we really do have the infrastructure and the resources, and it's just a culture change, a practice change, or a logistical change.
Mm-hmm. Yeah, just an anecdote on my end is just when parents come in with their child, and because I'm involved in the population, sometimes I know that the parents might be on methadone or Suboxone. And if everybody has COVID, nobody can bring them their medications, and the parent isn't actually the patient. So it's just then you have to find all these workarounds to get them their medication, or else they leave and they take their kid with them. So it's a problem. Tommy, I just want to get to some of the other questions and not take up all the airspace here. So today in the news, there was an article that a school in Moncton was unable to take the kids out to do a cleanup for Earth Day due to the number of dirty needles on the property. Should engaging teaching of harm reduction be an avenue in the schools? We see this around our clinic. Me and my kids, we found a whole mason jar full of needles, just 5 blocks in each direction. So it's a big problem. So I'm not sure what the question is, other than maybe education is beyond just healthcare providers, but rather into schools and with our educators as well.
Yeah. I think education is crucial. As I mentioned before, the limitations on education, I think, are just that policy needs to match it in terms of supporting people to change their behaviors and change their attitudes from a caring perspective. I'm not familiar with that news article in Moncton, and obviously it's unfortunate when kids can't, do their whatever they were going to do outside and feel safe. But I think, as Debbie mentioned, the local organizations are picking up and cleaning needles as much as they're distributing them. And I'm aware of the peer programs in Atlantic Canada where people who are still using or using drugs are being paid to go out in the community and connect with people and pick up those needles. And so I think there can be wonderful opportunities in that as well to help empowering people while keeping everybody in our community safe.
Mm-hmm. Mm-hmm. Some presenters talked about those vending machines. So the question is, did they have to pay for that product? Who's buying these lovely vending machines that are out there?
Yeah, I imagine it depends on the program, and we don't have anything like that in the hospital in Halifax. So I'm aware some of them are more expensive, kind of higher technology with like palm print scanners and stuff. Those are some of the ones they're doing for safe supply. But some of the other folks here, Debbie, might be able to speak more about funding sources. But like all public health interventions, it takes some investment to see the benefits to keep everyone safe. So I think it's great if it can help people access harm reduction with fewer barriers.
Yeah, and there was a comment sort of about what about engaging local businesses, sort of local community members that would have an invested interest in keeping their areas safe, and could they, be part of that solution? And then one of the audience members talking about models in Ottawa where, and we have this in St. John too, sort of a powerful local advocate looking into like smoking cessation programs that are like, very operationalized. And so, is there something to learn there that we could use and kind of piggyback from in terms of drug use? So yeah, and lots of people who just want to connect with you. So I suspect you'll get some emails.
Oh, great. Yeah, happy to chat. And like I said, we're working on all this stuff in Halifax. So folks who are already doing a lot of these things in hospital, I'd love to learn from you as well.
Awesome. I've been looking at the Q&A. So, can Tommy speak more to the safe consumption site in the Royal Alex in Edmonton?
Yeah. I don't work there. I got to visit a couple of years ago during the stimulus conference. So I know things are changing all the time. But it is a dedicated set of rooms in the hospital, accessible from outside for emergency department patients, but accessible for inpatients. In a part of the hospital that's a bit separate from the rest of the clinical inpatient unit. So people can just head to the elevator, head down a hallway, and not necessarily have to be visible that they're accessing the site. And it is run kind of under the auspices of their specialized addiction consult team, which they call ARCH, which stands for Addiction Recovery and Community Health. And it's a multidisciplinary team with medical nurse practitioner, prescribers, social workers, people with lived experience as peer support workers. So because it's kind of in this medical model, they do keep track of who's accessing it, whether that person has been referred to their specialized team or not. And then they're able to check in with people if they're needing to go to the site. Do they need more substances to kind of take with them? Are there unmet withdrawal and pain needs that they're having to go and use and inject, and that kind of thing? So they, like I mentioned, don't have to leave the hospital grounds, don't have to lock themselves in a bathroom, but can just go and use and inject indoors. There's no smoking component to it because it's inside, as far as I know. So that's another potential gap that could be met with a more creative model to support people who are smoking, but like smoking, crack or fentanyl or whatever. Yeah, I don't know if people have more specific questions about it, but that's kind of how the model works.
Yeah, it was coming from Duncan Webster. So I'm going to call you out, Duncan. But and then I think you mentioned that they are collecting data and sort of watching what happens as they initiate these things. So that was one question. But can they use their own drugs, or is it only hospital prescribed drugs? And then are there any other sites beside the Royal Alex in Canada?
Yeah, as far as I know, the rooms are kind of split now into a safe consumption site that people can use their own drugs, and which they would have had to get somewhere, and their injectable hydromorphone opiate agonist treatment where people can come and get liquid hydromorphone to use there to inject themselves rather than have a nurse administer it. The full description of the program was published open access in CMAJ a couple of years ago. I'll put the link there, and I'll also throw that into that folder. And I can share a link to the folder again. And then in terms of elsewhere, as far as I know, at Royal Alex in Edmonton, St. Paul's in Vancouver, and Casey House, which is an HIV specialized hospital in Toronto, are the ones that have integrated safe consumption sites or overdose prevention sites into hospital care. But if we can locate these sites in a place in a city that's next to the hospital grounds or on the hospital grounds, and maybe more accessible for people who are still sick.
Awesome. Thank you. Hopefully that answers some of Duncan's questions, and I'm sure he'll find you if he has more. And Linda, I think I messed up your question. It wasn't who's paying for the vending machines. Do people have to pay to use the vending machines to get stuff and things that are available through the vending machine, or is it just for free? Is that?
I see there, Debbie's written all items are free, which I think might be in response to that question.
Sorry.
But yeah, that's depending on the vending machine and depending on the program. That's my understanding, because it's all about engagement and access, right? Like getting people the things they need to stay safe. So provided for free generally if we're talking about sterile injecting equipment, or provided through programs and provincial insurance if we're talking about medications for safe supply.
Beautiful. Okay, Tommy, do you want me to let you off the hot seat because you've answered most of our questions? And always wonderful to have you, and thank you so much. And Randy, I will pass it over to you.
Okay, thanks everyone. Bye-bye.
Thank you, Sarah.